to host this webinar with two key opinion leaders in this field, in the field of myeloma. One is Professor Niccolò Bolli, and the other is Professor Niels van der Donk. They will both give a lecture about sequencing and resistant mechanisms to novel therapies. And I think this is a very hot topic. As you all know, we have different agents pertaining to the immunotherapeutic field. We have monoclonal antibodies, we have bispecific antibodies, CAR T-cell therapies. We have several drugs targeting the same antigen, but we also have different antigens to be targeted. So CD38, BCMA, GPRC5D, and there's a lot of interest in understanding what the mechanisms of resistance to these agents and targets are, and how we can potentially sequence different agents now that are all available, and most of them with the same indication. So without further ado, I ask Niccolò to start his presentation. We'll have then Niels's one at the end of Niccolò's, and then we'll take questions at the very end. Niccolò, please, the floor is yours.
All right, Roberto, thank you very much. Thanks to Mattioli and the sponsor for allowing me to talk about sequencing and resistance to novel immunotherapies. So I presume you can see my slides, so I'll get started then. So we don't need to introduce myeloma, but a couple of points we want to make from here is that while we're doing quite all right in treating myeloma in first line, we do have a problem in patients with late relapses, because we do know that as patients relapse a second, a third, a fourth time, eventually responses are historically of lower quality and shorter duration. So we need to work on the later lines of treatment to improve, well, of course, as well as in the first lines of treatment, but today we're going to talk about the later lines of treatment to improve the patient's prognosis. And how much do we have to work? So this slide has gone slightly bad, but I think it's understandable. So these are slides coming from the recent EMN meeting in Athens. And what you see plotted here are the estimated PFS of progression-free survival for patients receiving Dara-VRd or VRd as a comparator as first-line treatment for multiple myeloma. And it was discussed how we do expect a median PFS for patients on the quadruplet regimen of 17.1 years, which is a staggering number, which tells us that we're doing quite all right in terms of responses to first-line treatment. On the contrary, according to current standards, this is the locomotion study, so it's one of the many studies that tell us how our people that are triple-class exposed, triple-class refractory patients, those patients don't live long, not in terms of PFS, nor in terms of overall survival. So 4 months or slightly more PFS for patients triple-class refractory without the availability of novel immunotherapies. And why is multiple myeloma so much worse in later lines than it is at diagnosis? There are several papers now that we have, we as a myeloma community, so several groups have contributed to this. What we know is that at later lines of relapse, myeloma is genetically and phenotypically more aggressive. We have more chromosomal abnormalities. We have more inactivation of tumor suppressor genes. We have a higher proportion of genetic high-risk features in multiply relapsed multiple myeloma. And the bottom row looks at proliferation of plasma cells, which is usually not a prominent feature in multiple myeloma, yet myeloma cases at relapse converge towards a more aggressive and proliferative phenotype, which in turn, in the bottom right hand side, correlates with poorer survival of relapsed cases. So there is some clear biology behind the poor prognosis of myeloma at relapse that we need to overcome. And therefore, we'll talk about how to overcome these factors thanks to novel and not so novel immunotherapies, as Roberto was implying. So what are our tools to work on the immunotherapy side for multiple myeloma? This is a very general slide. We do have, in the clinic, monoclonal antibodies, and of course, anti-CD38 and anti-Islam F7 are the two ones that are available right now. We do have CAR T cells, of which only anti-BCMA CAR T cells are available in the market so far. We do have bispecific antibodies, and we can target BCMA and GPRC5D so far. And we do have ADCs that can only target BCMA. So these are the tools we can work with. Therefore, we can start asking, while these tools work extremely well and much better than what we had before, what happens in cases that do not respond? And here is a first paper that was looking at a combination that's not on label in Europe, of course. That's Dara-KRD first line in newly diagnosed myeloma. We do have Dara-VTD, and soon we'll have Dara-VRD. But the point I want to make here is that conventional cytogenetic high-risk features seem to still confirm a poorer prognosis, even with this highly effective first-line regimen. But if you want to segregate patients in good responders and poor responders, of which there are few, by the way, because again, we're talking about regimens that would cause a durable and deep response in the majority of patients. But the few poor responders are characterized by genetic features that are not necessarily captured by current, let's say, genetic prognostic scores. And I'm talking about some deletions in chromosome 22, chromosome 16. 1p is in our list. I'm talking about mutational signatures, which is a fairly advanced way to catalog gene mutations. Icaros deletions, very rare, but they were a fairly interesting finding of this paper. But we're talking about immunotherapies. So I think it's only fair to say that if you want to capture why those immunotherapies don't respond, you don't have to look only in the plasma cell. The immune microenvironment is also relevant for response. And here we're talking about a finding that was recently published by the group of Niels van de Donk in Amsterdam, where responses to daratumumab here in the context of the Cassiopeia trial were, of course, very deep and durable on average, but patients who failed to achieve MRD or had a less sustained response showed a skewing in their baseline NK cell ratio towards a population that has a brighter expression of CD56, CD16 negative. Those are cells that have a lower cytotoxic potential, so ADCC would be much lower. And it's clear that this is only one of the many papers that tie the composition of the microenvironment to responses to daratumumab. So there is something to be learned there and potentially to be improved, even though, again, first line, I think we're doing quite a good job. The problem comes in later lines. So in later lines, we do have different drugs and different targets that we can employ. And drugs are especially bispecific antibodies and CAR T cells. Targets are so far BCMA and GPRC5D. So those agents have transformed the landscape of, let's say, triple class exposed multiple myeloma to be as general as possible, with durable responses that are unprecedented. Nevertheless, even the best drug, the best response is supposedly not a cure and relapse will follow sooner or later. So why would patients stop responding or not respond in the first place to these highly active agents? So of course, because those are very targeted antigens. Those are drugs targeted against a very specific antigen. The first thing that we did was, well, we and, again, as a myeloma community, was to look at the actual target, BCMA, in the case of CAR T cells, as shown in these papers. And what was found is that the BCMA locus is often deleted. Usually one copy is often deleted in multiple myeloma at relapse, and after treatment with anti-BCMA CAR Ts, even the second copy of the BCMA locus could be lost. That was described in two very small case series, and that was a clear mechanism of resistance. You lose the antigen, you lose the target, the drug is not working anymore. This happens, it's not the only explanation of resistance, but what we see in the bottom right is that if we look at the locus of BCMA, the locus of GPRC5D, these are in areas of the genome that even before starting immunotherapy directed against these targets, these loci are heterozygously deleted, and potentially patients left with one copy are more prone to losing the second copy, and this could be a predictive biomarker. So how often do we see deletions of the BCMA locus after treatment with CAR T or bispecifics? In this later paper by the Calgary group, it was found that about half of patients relapsing after CAR T or bispecifics, the BCMA locus was deleted or the BCMA gene was mutated in about half of the patients. And this is often a very deep branching evolution, meaning that bispecific antibodies and CAR Ts are very much able to eradicate the bulk of the multiple myeloma, if you see the dendrogram here at the bottom. And often the clone that escapes BCMA is a very tiny clone, perhaps even undetectable at diagnosis or before starting treatment, that nevertheless is there and is able to repopulate the whole myeloma and therefore cause relapse. So that is a fairly daunting phenomenon that we are facing with these targeted treatments. And this is potentially even more the case if we switch to the other target. So while for BCMA antigen loss is felt to be about half of the cases, if we look at GPRC5D, this target, despite being very effective and drugs against it being very effective, plasma cells are even more prone to losing GPRC5D through genetic or epigenetic mechanisms. And in this case, you see on the left, there was one patient who accumulated 7 different mutations in 7 different subclones that would dictate resistance to anti-GPRC5D agents. So that seems to be a target quite easy to lose. So again, we do lose BCMA frequently. It looks like bispecifics exert a higher selective pressure for losing BCMA. And what's also interesting is that patients that relapse because of BCMA loss often do so after responding, not earlier than 6 months since the start of treatment. So it looks like this selection process takes some time, and usually this antigen loss happens later. So of course we can then ask, what if patients don't respond in the first place? And that, of course, is the case in about 1/3, 40% of patients. They never respond to anti-BCMA agents. And there can be different explanations there. One is BCMA could be overexpressed. So instead of lost, we could have too much of it. And there have been description of patients with overexpression of the antigen due to amplification of the chromosomal locus. So having too much BCMA will skew the target to effector ratio so that either CAR T cells could not expand to the point of killing plasma cells effectively, or bispecifics could stoichiometrically be not enough to exert this function. And this has been again proven in vitro on the left-hand side by engineering myeloma cell lines to express more BCMA. What those plots show on the left is that if cells express more BCMA, you need a higher concentration of the drug to effectively kill the cell line. You eventually will get there, but you need to be mindful that the dose of the drug needs to be higher. But then there's a second twist to this. So BCMA is not only bound to the membrane of the plasma cell, but can be cleaved and released in circulation. So myeloma patients do have soluble BCMA. And the hypothesis is that the presence of soluble BCMA could act as a decoy target and cause a sink effect. Basically, capturing all the anti-BCMA drug that we administer and therefore causing ineffectiveness of the drug itself against the actual myeloma cells. So this also has been shown in vitro by simply adding soluble BCMA to the medium of cells. And on the right, you can see that while the killing is highlighted by a shift to the right of those plots, in the presence of a lot of soluble BCMA towards the top, those plots will shift back to the left, which means no killing anymore. So the more soluble BCMA there is, the less anti-BCMA agents are able to kill. But then again, these are immunotherapies, so it's wrong to only look at the plasma cell to explain resistance. And there has been this seminal paper from the Heidelberg group, where it was found that, well, not surprisingly, I would say, but this paper was super elegant in demonstrating it. Patients that do not respond to bispecifics often had an exhaustion of T cells before even starting the drug. So CD8 cells, which are the ones that we suspect are responsible of the killing, even though those are not the only ones, would express more exhaustion markers like TOX, for example, or others like TIM3. Patients enriched for those exhaustion markers would fail to respond properly to bispecifics, regardless of the antigenic status of the BCMA on the plasma cells. So indeed, what was found is that exhausted T cells don't kill, they don't exert cytotoxicity, they don't expand clonotypically as they would have to. And also another twist that is immunologically quite interesting is that while CAR T and bispecifics should have an MHC-independent killing of the plasma cells, and that's part of the reason why they should work so effectively, in fact, presenting antigens on the MHC and on the MHC class 1 by the plasma cell is a very powerful way to enhance response to those immunotherapies, and plasma cells might downregulate MHC class 1 again as part of their mechanisms of resistance. So going towards the end, I'm just going to summarize what we discussed. So if we want to look at why novel immunotherapies don't work, and of course Niels will tell us that they do work, but I'm just covering my bases here because of course we need to look at both sides of the coin. So of course those novel treatments might fail to work because of plasma cell intrinsic phenomena like antigen downregulation, increased soluble BCMA levels, MHSC downregulation, or simply because of tumor biology. We have so many cells that the molecule or the CAR T cells cannot overcome the burden of the disease. And of course, the other half of the moon is the immune microenvironment, where the T cell population and its composition is crucial. So while this is especially true for bispecific antibodies, it is also true for CAR T cells. It's sometimes hard to disentangle, what's specific to the one or the other drug classes. But of course, in the case of CAR T cells, there are specifics that need to be mentioned, such as the bridging therapy, which is not something that we do in bispecific treatment, the lymphodepletion, which again, we don't do for obvious reasons in bispecific antibodies treatment, and the pre-manufactured features of the patient's T cells. And we know that the ratio of CD4 to CD8 is important to a successful manufacturing of CAR T cells, and of course, the fitness of the T cells themselves. Plus, of course, the way the CAR is manufactured. And of course, there's no time to cover this in detail. So just to outline the conclusions and a few discussion points, we know that antigen loss is frequent for bispecifics. It's frequent for BCMA, half of the cases, perhaps slightly more. And we see antigen loss much more in bispecifics than we see for CAR Ts. T cell composition is important for both class of drugs. Perhaps for CAR T cells, this is even more important. In bispecifics, certainly the baseline T cell fitness has been proven to be important. For GPRC5D, most cases that will relapse will have lost the antigen. That looks like the preferred mechanism of action. And from this, we should learn. We should learn how to improve the way we administer these treatments, whether we can bring patients to the treatments with better holding, bridging therapies in the case of CAR T, and how do we factor this in for the sequencing of CAR Ts, bispecifics, BCMA, GPRC5D regimens, and whether this can become part of our, let's say, routine clinical decision-making process in the future. So with this, I have nothing else to say. Thank you for your attention. I'll pass the mic over to Niels, and I think we'll have a discussion at the end.
Thank you, Nicolo, for your interesting presentation. I will cover some of your points that you raised from the more translational science. And maybe we have time to discuss some points that I did not touch, like dual targeting and with trispecifics or with dual targeting CAR Ts, which I think is also very interesting and very promising. So let's see if this moves. Yes, these are my disclosures. These were my disclosures, and here you see the outline of my talk. I will discuss something about CAR T cell therapy and early lines of therapy where it's now approved, and some practical considerations for use. I will discuss a little bit on sequencing immunotherapies, and then I will move to the bispecifics, where I will discuss the data in a triple class exposed setting, because bispecifics are only approved now in patients with triple class exposure. Also provide some practical considerations and how bispecifics are also moving to early lines of therapy where T cell fitness is preserved. So here you see the three antigens that are commonly used in myeloma for T cell immunotherapy, BCMA and GPRC5D, but also we have cevostamab, a bispecific antibody that targets FcRH5. All these antigens are expressed on myeloma cells, but also on some healthy tissues, and that explains some of the side effects that we see with these agents. that target either BCMA or FcRH5 or GPRC5D. So when we talk about T-cell immunotherapy, we have CAR T cells, cells that are manipulated in the laboratory to express a chimeric antigen receptor, and we have bispecific antibodies, which have two different binding domains. One domain binds to the T cell, to CD3, and one domain binds to the tumor-associated antigen, and thereby redirects the T cell to the tumor, leading to its elimination. So let's first focus on CAR T cells. We have currently two different CAR T cell products approved, cilta-cel and ide-cel. And cilta-cel is now approved for patients with at least one prior line of therapy plus lenalidomide refractory disease based on the CARTITUDE-4 study. And in this study, we demonstrated a superior progression-free survival with cilta-cel, as you can see, as compared to standard of care regimens. And also, importantly, with longer follow-up, it was recently demonstrated that cilta-cel also leads to an overall survival advantage in patients with 1 to 3 prior lines of therapy, including lenalidomide refractory disease. So in several countries, we can now give cilta-cel, and in some of these countries also to patients with earlier relapse with at least one prior line of therapy. So is it better to give cilta-cel earlier than later? Well, there is no study that compares in this head-to-head in the same patient population, but we can compare CARTITUDE-1 with CARTITUDE-4, and CARTITUDE-1 enrolled patients with much more prior lines of therapy. I think in CARTITUDE-1, patients had 6 prior lines of therapy, were mostly triple-class refractory or pentadrug refractory, while in CARTITUDE-4, as I mentioned, it's 1 to 3 prior lines of therapy. So better T-cell fitness in CARTITUDE-4, and this translated in a better progression-free survival in CARTITUDE-4 as compared to CARTITUDE-1, and also overall survival, as you can expect, was better in CARTITUDE-4 as compared to CARTITUDE-1. Cilta-cel is not the only CAR T-cell product. We also have ide-cel from BMS, and in the KarMMa-3 study with patients that had received 2 to 4 prior lines of therapy plus triple-class exposure. Also in this patient population, ide-cel was better than standard of care regimens with a median PFS of 14 months versus 4 months. So again, a CAR T-cell product better than standard of care regimens, but you can also see that the PFS with ide-cel is inferior to that what we can obtain with cilta-cel, with a median PFS of 3 years or even more. And on the right side, you can see that there was no overall survival benefit in KarMMa-3 study, and this is related probably to the fact that patients treated with standard regimens could cross over at the time of relapse to ide-cel. So 56% of the patients in the standard arm received ide-cel at progression. So when you consider a patient for CAR T, you should refer the patient early on. So do not wait for clinical progression, but refer as soon as the patient has early signs of biochemical progression. Early referral makes it easier for the CAR T center to provide CAR T because there is always a limited access to manufacturing slots. It also takes time to produce cilta-cel. It also takes time to produce ide-cel. And when you refer the patient early on, tumor burden is typically low. And that's important because we have now also clinical studies next to laboratory studies, also clinical studies that show you that when tumor burden is low, that the response duration, the PFS with CAR T-cell therapy is better. Also, when you refer earlier, you can select the best bridging therapy for your patient. And bridging therapy is very relevant to keep tumor burden low when the patient comes in with low tumor burden. And bridging therapy is essential to reduce tumor burden in patients that come in with a very high tumor burden. And if you look in the picture, you can see that patients that respond to bridging therapy, and that's the black line, that these patients have a much better response duration, much better PFS with cilta-cel than patients that do not respond to bridging. And the same is true with ide-cel. So patients that achieve a complete remission with bridging therapy have the best PFS with ide-cel, so no progression up till now, while patients with VGPR or PR to bridging therapy have an intermediate prognosis, but the worst PFS is in patients that do not respond to bridging therapy or relapse. Of course, patient numbers are small, are limited, and we need more data for ide-cel, but there are several other studies that show the same trend. Deep, effective bridging therapy, response to bridging therapy, low tumor burden at the time of CAR T-cell infusion translates into a better prognosis. So I think this is extremely important to prepare your patient towards CAR T-cell therapy. So other important teaching points are that there is no specific age limit for CAR T-cell therapy. However, frailty and individual physiologic fitness, cardiopulmonary fitness should be considered. And you can use pre-apheresis, the CAR hemototox score, to predict efficacy and safety. So this is my next slide, a little bit on sequencing. Also, when you have a patient that is a CAR T-cell candidate, I favor the use of CAR T-cell therapy first, before you move the patient to a bispecific antibody or to an antibody-drug conjugate like belantamab. Why CAR T-cell therapy first in CAR T-cell eligible patients? Why? Well, there are more robust data supporting the efficacy of T-cell engagers post-CAR T-cell therapy compared with the reverse sequence. So CAR T-cell therapy first and then a bispecific antibody is the optimal sequence of BCMA-directed therapies, at least today. So in the figure on the left, you can see some data from CARTITUDE-2, where you can see that patients that were previously exposed to an ADC targeting BCMA or a bispecific antibody targeting BCMA, that these patients have much lower progression-free survival than the PFS of 3 years that I showed you previously. So here you see only a PFS of 6 to 9 months when patients had previous exposure to ADC or bispecific antibody. And on the right, you see data with ide-cel, where you can also see that in patients with previous exposure to BCMA-directed therapy, blue, the PFS is lower than in patients without previous exposure to BCMA-directed therapies. So CAR T first and then a bispecific or ADC. So here you see some recommendations from the IMWG Immunotherapy Committee regarding sequencing. Also, the IMWG recommends CAR T first before T-cell engagers or ADC because of the deep response with CAR T, the long progression-free survival with CAR T, the treatment-free interval that also leads to quality of life improvement. While with bispecifics and with ADCs, you give continuous treatment, and this treatment-free interval with CAR T can be very good for the patient. However, CAR T is not always possible because in patients with very rapidly fulminant progression, you want to start a therapy directly, and you cannot wait for the CAR T manufacturing process. And these patients may still benefit from a bispecific antibody, which is off the shelf available, or an ADC, an antibody-drug conjugate. So in the green section, you can see some recommendations for treatment after BCMA CAR T. Both BCMA and GPRC5D immunotherapies are effective, but from the limited data that we have available, GPRC5D targeting therapy seems to be more effective than BCMA targeting therapies, probably because of the mutations and deletions that were previously shown by Dr. Bolli. And in the orange bar, you see some recommendations for treatment after BCMA targeting bispecifics. Therapy with a different mechanism of action or immunotherapy targeting a different antigen should be pursued. And efficacy data for sequencing BCMA targeting treatments of different modalities are limited. So when a patient progresses on teclistamab or elranatamab, I try to do something completely different to have T-cell fitness recovered, for example, on an IMiD-based regimen, and then I move to GPRC5D. This is not always possible because sometimes patients are very refractory to everything that's given before, and you have to go directly to GPRC5D. But I think when you sequence two bispecifics directly, the effectiveness is lower than when you have some interval during which the T cells can recover. And in the last section, I like to focus a little bit more on the bispecifics. So this slide was shown before by Dr. Bolli. In patients that are triple class exposed or triple class refractory, response rate with standard of care regimens is only 30%. We have a median PFS with standard of care of only 3 to 4 months and a very limited overall survival. So we really needed new agents for the treatment of triple class refractory patients. And of course, the results with the bispecifics are very promising. Here you see some data from teclistamab in 217 patients that were treated in the MajesTEC-1, but also in 2 different cohorts, a Japanese cohort and a Chinese cohort. And in all these 217 patients, we see a 66% response rate, deep remissions with mostly VGPRs and CRs, and we see a median progression-free survival of 15 months in all the patients. And if you achieve a CR, the red line, you do even better, with almost 60% of the patients free of progression and alive at 3 years. So very good results if you achieve a CR with teclistamab. These data are a bit better than in MajesTEC-1 alone, and that's because MajesTEC-1 also enrolled patients during the peak of the COVID-19 pandemic, while the Asian cohort started later on, and the impact of the COVID-19 pandemic was lower, so less COVID-related death in this global cohort of 217 patients. I thought I also had data from elranatamab, but first some real-world evidence. So teclistamab was also used in some retrospective analysis outside of clinical trials, and you can see similar response rates as in MajesTEC-1 on the left, and on the right you can see similar CRS rate, cytokine release syndrome rate, in the real-world evidence studies as compared to MajesTEC-1. And you can also see that infections are a problem in the studies and outside of clinical studies. So supportive care with the BCMA bispecifics, including infectious prophylaxis, is crucial. And then elranatamab. Elranatamab is also approved for the treatment of triple-class exposed myeloma based on data from MagnetisM-3 with excellent response rate, 61%, much higher than what I showed you from the locomotion study, and a PFS of 17 months. BCMA space is very crowded. We have BCMA CAR-T, we have BCMA ADCs like belantamab, we have BCMA bispecifics. So we also need other targets, especially in the context of BCMA mutations and BCMA loss. So we have now 2 GPRC5D targeting bispecifics. Talquetamab is approved, and forimtamig is developed by Roche. At least I should say it was developed by Roche, because its development has been stopped. Not because of side effects or insufficient activity, but because of the business decision. And on the left, you can see that talquetamab at the recommended phase 2 dose of 0.8 milligram per kilogram every 2 weeks induces 70% response in patients that were not previously exposed to T-cell immunotherapy with a PFS of 11 months. In the 78 patients that had received prior T-cell immunotherapy, you can see that the response rate is also 60%, but the PFS is a bit lower, 7 months. And this was higher in the patients with prior CAR-T and lower in the patients with prior bispecifics, probably related to T-cell exhaustion in patients with prior bispecific. So here's something about management of infections and management of CRS. So in patients on bispecifics, I start cotrimoxazole as PGP prophylaxis. I start valacyclovir to prevent herpes infections. I give vaccinations before starting bispecifics, and especially in patients on BCMA bispecifics, I start IVIG because it has been shown in various retrospective analyses that primary prophylaxis with IVIG protects against severe infections as compared to no IVIG. And on the right, you can see that you can manage CRS with proper step-up dosing, with proper pre-medication like steroids and antihistamine. But we showed in Amsterdam that also prophylactic dosing can significantly reduce your CRS rate from 60-70% to 10% without impacting response. And this paves the way to outpatient dosing. So we treat currently various patients in the outpatient setting with prophylactic dosing, which prevents CRS and prevents presentation at the emergency unit. And here you can see some recommendations for the management of GPRC5D associated toxicities. GPRC5D is not only expressed on tumor cells, but also expressed in the nails, in the skin, and in the tongue, in the papilliform, in the filiform papillae. And on target, off tumor side effects because of this expression pattern induce nail problems. Nails become frail, the skin can become red, or you get desquamation of the skin of the hand palms and foot soles. And because of the expression in your tongue, you can get loss of taste and also sometimes difficulty in swallowing. So here you can see some tricks to manage this. Brittle nails, you can benefit from nail hardener. I recommend emollients in patients with desquamation. If it's a generalized rash, sometimes you need also some prednisolone for a short duration of time, like 20 milligrams, 7 days. And for loss of taste, we don't have so effective solutions except of going to a less frequent dosing regimen. So from every 2 weeks, in patients that achieve a VGPR, you can quickly move to every 4 weeks. And then this has also been shown by Dr. Bolli, and there is increasing evidence that T-cell fitness at baseline is an important determinant of response. So patients with an exhausted T-cell profile have worse PFS. And on the left, you can see that patients with a lot of Tregs, the light green curve, also have inferior progression-free survival. So why not move also the bispecifics to earlier lines of therapy where patients have better T-cell fitness? And we have already some data that this is beneficial. When you look at Majestic-1 to patients with 3 or less prior lines of therapy, then your response is higher and also your progression-free survival is better, 22 months, versus patients with more than 3 prior lines of therapy. Lower response rate and a PFS of only 9 months. And the same is now being seen in the Monumental 1 study with talquetamab, where also patients with less heavily pretreated disease, the red curve, do better than patients with more heavily pretreated disease, better PFS. So these subgroup analyses from the early trials provide the rationale of moving bispecifics to earlier lines of therapy. And I will not go into detail, but here you can see some examples of large phase 3 trials in which BCMA targeting bispecifics are being investigated in early relapse and newly diagnosed multiple myeloma. And this is also true for GPRC5D, which is also now evaluated in newly diagnosed myeloma and early relapse. And there are early results that this approach is indeed very effective. For example, in Majestic 4 and also in Majestic 5, we have shown that teclistamab as maintenance or teclistamab as part of induction before or after transplant is very effective with, in fact, all patients achieving MRD negative disease. So very early results, but very promising, I think. So in conclusion, T-cell redirecting therapies are transforming the treatment of myeloma and other cancers. Appropriate adverse event management strategies are essential. And novel strategies have the potential to improve depth and duration of response, like combination strategies, and trials are ongoing. But we can already improve CAR T-cell therapy efficacy, bispecific antibody efficacy by, for example, giving very effective bridging therapy before CAR T and by giving patients access to bispecifics as early as is possible. So that brings me to my slide with all my colleagues in Amsterdam that, of course, helped a lot in the lab and in the clinic. Maybe I can now give the presentation back to our chair, Roberto, who maybe want to ask me and Dr. Bolli some questions.
Thank you, Niels. Thank you, Nicolo, for your excellent presentations. So I just like to remind all the people that are listening to us that if they want to ask questions, they can do it in the chat. And while we wait for questions, I certainly have many. So the first one would be probably for both, but maybe Nicolo can start. So we know we have some data and we speculated about mechanisms of resistance to bispecific and CAR T, but what about ADCs, particularly belamaf? Because you know that now we will have soon the approval of bela-VD and bela-PD in early lines. And this, of course, may affect the treatment decisions and the choice of going for a BCMA agent in an early line and then potentially impacting the late lines, the ability to give a bispecific or a CAR T. So what do we know about the resistance to belamaf?
Yeah, so this is a great question, Roberto, and there is no paper that would give you the definitive answer. So it was perceived by looking at efficacy in later lines that ADCs are effective, but slightly less effective than T-cell redirecting therapies. That was potentially not the case for the randomized phase 3 studies in earlier lines, but it's a common theme that as you move earlier, drugs are more effective. Now, we know that ADCs, similar to bispecifics and CAR Ts, rely on the target, rely on the immune system, and they work less if there is too much target, if there is too much soluble BCMA, if the T-cell population is not fit. I think that to what extent each of these factors contributes, it's a matter of debate. But we know, and it has been published in the past, and it has been published, I think, this week or late last week, how ADC before CAR Ts and ADCs before bispecifics will hamper the response to the subsequent T-cell redirecting therapies. So it must be through either antigen loss or T-cell exhaustion or both. So those must be the reasons why. That's my opinion, at least. No, I'm not sure what Niels has to say.
Yeah, I totally agree. There's not a lot of data on mechanisms of resistance of ADCs. There are, I think, 1 or 2 case reports that showed that also after ADC, after belantamab, BCMA expression can be gone. But this seems to be rare because there was a report from the DREAM studies that at the time of relapse, soluble BCMA was still there. So that suggests that BCMA loss was not a frequent mechanism of resistance. Maybe it could also be that the ADC, which is given continuously, is blocking the epitope on BCMA, blocking access of the. So if you give CAR T or bispecific after ADC, the efficacy is gone. So maybe it's not only BCMA loss, but also blocking access of. Maybe the ADC is blocking the access of CAR T to BCMA. So I think we need more information. I don't think that ADCs have a profound effect on T cell function, because you don't expect that, because it's targeted chemo. You don't expect that this will damage T cell function, but it for sure should be investigated in more detail. Nevertheless, we have data now that if you give ADC first and then CAR T or bispecific, that the efficacy is reduced. So there must be something with the target, either blocking access or maybe mutations, maybe loss. So we need more information on that. There's also some data that a washout period is beneficial with all these agents, right? So you can also wait 6 months and do something else before you move to the next BCMA therapy.
And another question is related to bridging therapy. So you just mentioned that bridging therapy is maybe very helpful in keeping the disease at bay while manufacturing for CAR T cell therapy, for sure, also reducing the tumor burden. And this may have an impact, although CAR T have a high affinity for BCMA, different from bispecific, but still you have less side effects. My question is, and in this regard, I would also like to hear from you about GPRC5D as a bridging therapy. You know, the results were presented at ASH with talquetamab, which is in Italy, by the way, is reimbursed now. So we may have access as a bridging therapy. In fact, not really, like from the reimbursement perspective, is not really clear, but we can play around with that. But the other question is, what about instead what Nicolas said about the resistance to bispecific antibodies? So the paper by Olili and Nizar about the high soluble BCMA tumor burden. So shall we consider to some extent, maybe in patients with very high tumor burden, extramedullary disease, some kind of bridging to bispecific? And if so, do you think that chemo, like all conventional chemo, because in a patient in 4th line, you don't have many options. So do you think like a cyclophosphamide may still be considered before giving a bispecific antibody, or should hamper the T cell function?
Yeah, so patients with very high tumor burden have a very poor response to bispecifics, right? By patients with ISS stage 1 do much better than patients with ISS stage 3. And ISS stage is then a reflection of tumor burden, which is sometimes difficult to measure. So if I have patients with very high tumor burden, I consider chemotherapy before the bispecific. I give 1 cycle of polychemotherapy and then move to the bispecific very early on, because we also know that responses to polychemotherapy are very short-lived in these patients. So I give, for example, CAD, cyclo, Adria, and Dexa. And then on day 15, when the patient is in the lowest, has neutrophils of 0, platelets of 0, I start a bispecific step up so that I prevent progression. And that works. The French have shown in a series of 60 patients that in patients with high tumor burden, with extramedullary disease, chemotherapy and then bispecific seems to improve response and response duration. Of course, it's retrospective and we have to be careful, but I think in these patients it works. And of course, radiotherapy can also be beneficial in patients with large lumps, with large plasmacytomas, to shrink them, to induce inflammation, so that the T cells can enter these hostile microenvironment. So we sometimes give patients with high tumor burden polychemotherapy by reducing tumor burden, optimizing effector target ratio. Probably it has also negative effects on T cell function, and that's why I prefer to give bispecifics earlier, as soon as there is biochemical progression, and prevent high tumor burden.
Okay. So maybe just one comment from both of you about the future direction for trispecifics and the potential of targeting dual targets with CAR T and antibodies. How do you envision this?
I mean, from a clinical, I'll start just because Niels has talked last. From a clinical point of view, I think it will be successful. Depends on, how strategically this is placed in the sequencing. but dual targeting has the potential to prevent antigen escape. There will still be a factor to target ratio. There could still be other factors preventing efficacy. T-cell exhaustion will be an issue, whether the dual targeting will put an extra layer of stress on the T-cells. I mean, it's to be seen. We're playing with the immune system, and we don't know the immune system that well. And Niels may correct me, of course, but I don't think we can predict this effectively. But clinically, I would be surprised if trispecifics would fail to improve even further responses that we're seeing now. Biologically, I will be puzzled to see how plastic the myeloma cell is, because of course then the selective pressure to lose both antigen will be potentially harder to achieve for a tumor cell. So I don't have the answer for this, but I have high expectations for these drugs.
Yeah, so there will be more and more information coming in the next few conferences. In the BCMA GPRC5D trispecific will be presented at ESCO. At last ASH, we learned about the CD38 BCMA trispecific with promising early results. The interesting thing about the BCMA GPRC5D trispecific from Janssen is that it also has very low CD3 affinity. So it binds to T cells with low CD3, with very low affinity, which may preserve in the end T cell fitness, may prevent T cell exhaustion. And it also leads to a better PK profile. So it can be given every month from the very beginning instead of every week, like what we do with TEG and with Elran. So we are learning, we are still in the beginning of learning and improving all these interesting molecules. And I think we are improving in a very rapid pace. And I'm also curious how the tumor cells in the end will escape. Will both be BCMA be lost and GPRC5D, or how will these tumor cells look like? We have now also ongoing studies with a trispecific targeting BCMA and GPRC5D plus daratumumab targeting CD38, so targeting in fact 3 antigens on the tumor. So we are improving our strategies as we speak, and of course we also have to balance with toxicity. We have probably to stop treatment at a certain time point in the newly diagnosed setting, in the early relapse setting, to have immune recovery and prevent infectious problems on the long term. So I think we are well addressing all these different issues in the ongoing trials.
Just one last question, very, very quick. Do you think with the trispecific targeting, for example, BCMA and GPRC5D, will be more selective in sparing the healthy plasma cells as GPRC5D is more expressed, or do you think you are still wiping out healthy plasma cells?
I think BCMA and BCMA is expressed on normal, GPRC5D lower on normal. So, but BCMA is also expressed on the B cells. So I think in terms of immunity, humoral immunity, I think I don't expect too much difference with tri and bi.
Okay.
But let's see.
I think we ran over time, and I thank you both, Niccolo and Niels, for your excellent presentations and your contributions. I hope everyone enjoyed this webinar very much. So thank you very much. I hope you have a great evening and see you soon.
Thank you to all. And at the next time, we have the next appointment at martedì 27 maggio. Grazie a tutti, buona serata.
Grazie.
Bye. Ciao, grazie.
Nice seeing you. I'll see you all very shortly. Have a good evening.
Thank you. Ciao, ciao.
Ciao.